So I'd like to thank you for letting me give this presentation today. We're going to talk about high dose rate brachytherapy emergency procedures. I think I'll just tell you a little quickly who I am. I've been a medical physicist for about a dozen years and practice in South Dakota, the United States. Right now I'm at a Vera Cancer Center. I work in two rural clinics mainly. And I just switched from previous employer. So my previous employer, I had worked with the Nuclotron's older afterloader, and then we switched to Gamma Med about a year ago, and now I just got a training on Flexitron. So I kind of have a good perspective on how emergency procedures, I think, can kind of flow between the afterloaders, since I know some of you may have a variety of afterloaders. So let's talk about the emergency procedures, and I'll just go through a quick outline of what we'll go over. I'll list some resources and references that you can go through on your own. We'll look at the types of emergencies. Those types of emergencies are really taken from an AAPM task group report. Looking at major emergencies and minor emergencies as well a little bit, but we'll mainly focus on major emergencies, on establishing policies and procedures, which is important, and education and drills, which is just as important or maybe more important. It's more of the practical part. Just as important, probably is better to say. Okay, so let's dive right into resources and references. Obviously, the report of the APM Radiation Therapy Committee Task Group is an important one. And that's number 59. It's worth it to take a look at. It's well written. It's an older report, but it's the safety aspects are really consistent and have lasted through the test of time. Afterloaders have changed and updated a little bit, but by and large, their major construction is similar. The technology hasn't changed fast enough that it makes any information outdated. You can look at the U.S. Code of Federal Regulations. I think that's good to look at if you're practicing in the United States, or if you are where you're practicing doesn't have many regulations. That would be a good guidance. They do have good suggestions on what you can do. IAEA Human Health Services Series number 30 is good to look at. And I would say, really for the regulatory, you got to look at your federal or local regulations, because they do change, obviously from where you are. I didn't have a chance to look up the regulations for where each of you are practicing, but I am guessing that many of you do have some rules, so it's important to be aware of those as well. There's types of emergencies, and so these are taken from that task group report. They call them physical plant emergencies, minor emergencies, and major emergencies, and we'll just go quickly kind of through the first two and concentrate on the second one. But it's important to be aware of all three. Physical plant emergencies is what they call. This would be like your natural disasters, fire and flood. You need to be aware of your institutional procedures. I think that's important, to realize that we're all practicing within clinics, and that our procedures that we wanted to do with our HDR units need to mesh well with the procedures for the clinic at large, so that we don't have any confusion should a disaster of this type happen. They should be reviewed with respect to source security and safety. So you should take your clinic's procedures, like what they do in a fire, and think about how would that affect what I'm doing with my afterloader. If they ask me to evacuate because of a fire and I have my afterloader out in the room doing a treatment, what do I need to do to secure that source? More importantly, keep the patient safe. What steps do I need to take? So I think that's an important thing. I think that when I first started to do procedures, I didn't think about, I sat and just did my own procedures. And then when we started to really think about how they'd work, I found some things that, I need to change that because our policy with the clinic says that we need to do, we need to check doors or something in terms of, they had me doing something else in terms of a fire or a flood. So we just need to kind of refine those with the entire clinic. These emergencies may be accompanied by power loss. That's important to realize. And they might rely on the power failure retraction response to the afterloader. That's a really, really important feature of your afterloader that needs to be working before you treat. So that's one of the things I'm sure you went through on your QA. That's also important with emergency procedures. That has to be in place and working. So moving on to minor emergencies, these would be more of abnormal device performance, and you're going to get probably an error code from your machine. What's really good is to become familiar with those error codes and what they mean. I'm sure we've all had error codes pop up on a machine that we're not quite sure what they mean. I'm new to some Electa machines that I'm working on now, and I've had some error codes pop up that I have to go look and see what they are. What's really good with an HDR and with the emergency procedures is that you have maybe a binder or a book with the details of those codes available at the console. That way, if you do have an emergency, a minor emergency, and you have a patient being treated, you won't have to scramble to try to find out what that error code means. Those situations are stressful enough that having that information at your fingertips is always nice. Examples of these errors might be to an unattached or kinked guide tube or an unclosed vault door. I know I have had that with an afterloader. I'll have a forget to lock the indexer ring or something, and it'll give you an error message, and it might not say indexer ring unlocked. It might give you a different error, so you need to be aware of what that means so that you can fix it quickly. But once again, these are emergencies that aren't, we call them maybe emergencies, but they aren't ones where the patient's in any sort of grave danger. Moving on to the ones that we want to be aware of the other ones, but we really are be concerned with the education and the practicing of the procedures here are for major emergencies. They're going to require physical intervention, meaning you're going to need to go into the room, most likely, and interrupt that treatment. And you need to have really solid emergency procedures established. And I should have probably put on there, established and have a good training program, a good drill program, and a retraining program. That's just as important as to have it established, is that you actually review it and go through it consistently. Example of this would be a patient medical emergency. Your patient we're working with sick patients, they may have a medical emergency, or the source, it's unlikely, but it does and has happened, a retraction failure. You need to enter the room and physically remove the source or retract the source. So, types of emergencies, major emergencies. Let's go through the things that we need to consider. We have various types of treatments. We have different types of applicators that we're going to use. A skin applicator treatment is going to be much less invasive than a gynecological applicator. Those are going to be different in terms of the way you have to respond and the speed of the response. The equipment needed. Okay, what do you need to remove a source from a patient, and where are you going to put those in the room? The location's important as well, because time is of the essence, and we want to be able to move swiftly, but we don't want to be racing around the room to try to find things. We're going to want to know the dose of the patient and be able to kind of estimate in our mind what's happening with the patient, and we'll need to do the same thing with dose to staff. And then after we've made sure the patient and staff are safe, what do we do about the source security in a type of emergency? So I'm going to first go through the equipment needed. You're going to need a survey meter. A GM counter is good if it needs to be checked to ensure the response is appropriate in a high dose rate field. This is a Ludlum 14C with a 44-9 detector or probe. We did put this in the room on the meter reading we were going to use. The scale we were going to use, and sent the source out to see and then put a camera on it to see what the meter would do in that type of field. I think that's important because if you have a meter that underresponds or goes dead in a high field, you need to know that. So I would test your meter. I would even test your meter, once you get it, don't just take my word that this meter is good in that field. Test it in your own field. That's a good thing to do. And a stopwatch. A stopwatch is good to have at the console. These are the things that you need right by your console. You'll see my keyboard right there. That's the treatment console computer, and it's right handy for me to check and use if I need to. That is a lead container. Sometimes they're called lead pigs. This is a lead container we use this is supplied by Varian. It's the Gamma Med one. I know the Nucleotron one, if they're supplying you with one, or if you've gotten one from somebody, is white with a little lid, and it has a handle that you can kind of roll it along. This is just another version. You'll need one of these and a cover for it, preferably, and a forceps, okay, so that we can grab the wire if we need to. Forceps or tongs, either one works well. You might want to think about that, whether you want the locking or not. I think that's kind of a preference, and I think you could argue which would be better. In-room radiation monitors, these are very important. So this is a prime alert. This is going to be able to tell me whether a detectable amount of radiation is present in the room. Now, I'm going to make a caveat right away on these guys, okay? I've had these fail, so you need to check that they work on your morning QA. They can get bumped. The power packs for these can get bumped, and I've had them fail. Also, with a larger patient and a weaker source, while that source is in the patient, I've had situations where the prime alert isn't sensitive enough due to its placement in the room to be flashing. So that's something to be aware of as well. If the source is inside the patient and a very low strength, it might not respond like it does when the source is out. Okay, equipment should be easily and quickly accessible during a procedure while allowing staff to move the patient from the room unimpeded. I think that's important when you're thinking about your procedures, that you're going to have to move that patient, and if they're on a gurney, you're going to have to move that gurney out. So you want to be able to make sure that if you have a lead container, it's not sitting in a way where we can't get the patient quickly out the door if we need to. The next thing we need to consider is dose to the patient. A dose reconstruction with regards to patient dose might be required depending on the nature of the emergency. So you'll want to think about, when you do drills on your procedures, what kind of information would I need to do a good estimate of the dose that the patient received. So we're going to have to know the time dwelled and the location of the source. And I would think that most of the consoles that you have and the afterloads you have will give you that information. If they don't, we'll have you'd have to address that. The assignment of one team member as recorder of time patient and staff are exposed to the source is also helpful. I say this because the computer should make these record the location of where the source is, but once you're hit interrupt or stop, or if the power fails, or if there's some failure of the unit itself, you're not going to get a good estimate of how long that source has been out and in the patient. So you'll need to know that as well. That's why that stopwatch is there. And I think it's important to assign a team member to do that. I think someone other than the physicists themselves, the physicist is going to have enough to worry about during that procedure, that having them worry about stopwatch as well is, in my opinion, is not wise. In our clinic, we had a nurse do this. So the nurse was aware that during that procedure, when I said, you please start the stopwatch, they would start the stopwatch and keep it going, and realize that they were responsible for estimating the time that the patient was exposed, and to know where staff were in the room and approximate times that they were exposed as well. Okay, dose to staff. So these are some good rules of thumb to keep in mind. For an unshielded 10 curie source in 1 minute, the doses at a centimeter are about 730 centigrade. So that's a significant amount of dose. At 10 centimeters, you're down to 7.75 centigrade, or centigrade, excuse me. And at 1 meter, you're not even a tenth of a centigrade. I point that out because we're really concerned about the patient dose in an emergency. The physician's hands, if he's removing the source, are going to get a little bit of dose, but by and large, the dose that we're concerned about is to the patient. If I'm in the room at 1 meter away from an unshielded source, if the source is out, it's less than a tenth of a centigrade in a minute, you can think of how much less the doses are if it's inside the patient or if I'm standing behind the afterloader itself with some shielding there. What we like to do, and this is also from that task group report, we'd like to keep the emergency response to 1 to 2 minutes if possible, because that's going to keep the patient dose values as low as possible. Remember that, I'm take a gynecological treatment with might be 5 minutes for a vaginal cylinder. So it doesn't seem like 1 to 2 minutes is that long, but remember it's dwelling in one position for that 1 to 2 minutes, whereas a gynecological procedure, it might be at several positions along maybe a 3 to 4 centimeter length. So they are going to get a significant amount of dose when an emergency response is required, and we just want to keep that as low as possible. Largest dose of staff is going to likely be incurred to the physician's hands if they have to remove the source. I like to tell my staff and keep them aware of how much dose they'd receive so that if we do have an emergency response, they're not panicked. They're not worried. If I have the physician coming in, they're not overly worried, or that it's not on their mind, how much dose am I getting? Now, I would like to say you need to consider how to address a pregnant staff member or a potentially pregnant staff member. I think that deserves special attention. In that case, you definitely are worried about the dose to the staff member. So you'll have to think about that when you do emergency procedures as well. Source security. Okay, the first thing we want to do is get that patient safe, make sure the staff are safe. But after that, you're going to want to keep that source secure. I think most regulations out there are going to have some stringent requirements for a source security for a source this large, and you need to consider that as well. The policies and procedures should be tailored to your specific afterloader model. If you received your afterloader from a vendor, they should have given you these procedures. If you received it from someone else, I think they could definitely supply you with those procedures from the vendor. The vendor is required to do that if you purchase it through them. So these are out there for nucleotron and variant. They can certainly be obtained and used in your department. Vendor supplied information and emergency procedures should be utilized in the development of those procedures. And there are flow charts which they can provide as well. I would like to make a comment on posting things in the room. You want to post something and a flow chart and a procedure and a list of numbers by the console and in the room so that people can consult them in emergency. We all know when you get an emergency situation, your brain doesn't work quite the same way as it does in that non-stressful situation. So it's nice to have that information there. Along with that, I think the simpler, the better. Posting, I think an early rendition of my emergency procedures, I think I started to post, 2 to 3 pages of information on emergency response. And then I kind of looked at it, I said, no one's going to read this in an emergency. No one will have time. So I simplified it. You really want to keep your brain into thinking, what do I need in the emergency? Keep bringing it back to that point. And I can't stress enough how important this is, education and drills. Initial education is important, but the drills and repeated drills, they need to be implemented. In the United States, the Nuclear Regulatory Committee or an agreement state requires it yearly. I think that's a minimum. I think it's just a good idea. Every time we do drills, I know that we think of something else. We're like, oh yeah, that would be a good thing to change about the way we do it. And so I think we only get better and better as we do drills. I'm thankful I've never had to be involved in a response, but if I had, I know I'd be better now than the first time I did a drill. So I think repeated drills are very, very important. And they should be developed with some respect to a realistic clinical scenario. And I think the thing with drills too is, I'm going to give an example of one in just a few minutes. They don't have to be perfect. In fact, it's almost better if they're not too scripted, because then you start to see what can go wrong. You see areas which you might need improvement on. I think that's a good way to learn. Here is an example that I've used before. This was in 2019. We just did this at my former hospital I was at. We had a tandem ovoid procedure. We said, it would become stuck in ovoid 2 upon retraction. And all attempt to retract the source, as listed in the emergency procedure that we had posted on the wall, failed. The treatment was complete in the ovoids. And we'll say that the scenario is going to be recreated by hooking up a transfer tube and running through part of a test plan. And then we'll just use the interrupt button, so that's going to be our mock retraction failure. And we're going to have a nurse and a physician and a physicist there. I think it's okay if you want to have a nurse play the role of a physicist, or the physician play the role of a nurse, or physicist be one of the other roles as well. That'll help you all kind of think about what might go wrong. I think, but ultimately, I think you also do need to do a drill with your in your own role, and then afterwards, make sure you discuss it. I know in my clinics, everyone wants to quickly get out, sign their name that they were there, and go. But I think it's important to talk about what worked and what didn't work. I know that when I like to schedule these when people aren't rushed, because the conversation gets good if you have the opportunity for it. So I think scheduling a time that works for everybody is important for these drills as well. I know that's difficult. And I think it's important to consider how that would be different for other scenarios. Like I said, a gynecological applicator is going to be vastly different than a skin applicator. Skin applicator, a retraction failure, you could easily or more easily drop it in that lead container, whereas a gynecological applicator is going to take a little work to remove. So I have an example here. I'm hoping this will play. I tested it before. I think what's important, I'm happy with, we did a drill, and this is rough, and I was going to use it just as the first run through and then do another kind of polished one. But I kind of thought about it, and I said, I don't want to do that, because I think it's good to have, to show that you just need to do it. It doesn't have to be perfect. And some of this roughness is what's going to happen in an emergency situation. You're not going to be polished. There's going to be some rough edges. So I left it the way it was. I didn't do it again. And this is a Gamma Med afterloader. So if this doesn't look familiar to you, if you have a nucleotron afterloader or a VeriSource afterloader, this is the Gamma Med version. I'll play this.
Hey Steve, we can't hear the audio, so perhaps if you could narrate and say what's happening.
Okay. Just let me pause it. Is the audio not working?
I think it's projecting from your computer, so like you can hear it.
Oh, okay. Yeah, that makes sense that it would. Okay. So what I will do then, if I narrate over the top of it, will that be distracting, or should I try to mute it? Well, I think this is what we'll try to do. So I'm gonna just stop it right here. So what we've seen so far is I started the test. I just had a mock source, let it go through its check sources, and once the source was out, I checked the prime alerts, they were going, and I hit the interrupt button to be a mock treatment. What was happening there was that the source was not going. What we were saying was the source was not retracting, so I hit the emergency button on the console, And then I've just asked the nurse and physician to be aware that I'm going to be going into the room with a meter, and that I have asked the nurse to start the stopwatch and take note of where we are in the room. I'll narrate live for the rest of this. Okay. Now, go back to that. Okay. I'll start from the beginning. See. So we're starting over at procedure. I remember, once again, this is just a test plan, single channel. You can use your morning QA plan. You don't have to do anything fancy. I'm just allowing the checkpoint runs to go. I'll be moving up, and you can see my prime alerts right here. Hitting interrupt. Okay. I'm going to hit the emergency stop. I'm asking the nurse to stand by with stopwatch. Grab your meter and enter the room. And there's the gamma med unit. My survey meter would be going off at this point. There's a hand crank. I'm saying it's stuck, so that didn't work. I've just called the doctor in to remove the applicator. Note the location of the emergency equipment, and I'll talk about that later, the placement I have. I'm calling in the nurse to help take the patient. We would put the cap on the lead container. You want to check your prime alerts, check your radiation meter, try to get an idea of what's going on, and we're going to move that patient to into the anteroom or the console area. We don't want to move them out into a patient room yet because we want to make sure that source is out. So we're going to close that door behind us, and we're going to survey that patient once more. And hopefully that source is in the room and not in here. Okay, if we find no radiation, we'll dismiss the patient. And then if the patient no longer has a source in them, which we're probably fairly certain they don't, but we need to confirm that with the meter, we'll allow that patient to go into a room, and then we'll want to make sure, your room should be shielded at this point for a source that's out in the open. So you really shouldn't have a worry about the radiation in the console room, but depending on how your room is shielded, you may want to make sure that the levels are okay right here, but I would assume your shielding is fine. What you'll want to do now is have a plan for the security of that source. Okay, and that has to depend on the practicalities of really making sure that source is secure and that nobody enters that room, and also on your regulations. What we did is we had a system, a badge system on our doors that I could call security and remove all access to the room, which was good. And another thing that we had talked about doing was to do a brief radiation safety training with an emergency or with a security guard, and then post them at the room until we can get a plan together after we've called the vendor and called the people we need to call, your radiation safety officer, your department manager will want to be aware, and definitely the vendor. so that we can figure out how we're going to address this. We may want to post a security guard at that room, depending on how certain you are that no one will be entering that room. Because at this point, that source would be unsecured, but inside the lead container. I would like to note that when we did this drill, I think the placement I had that lead container is not good. I think it was right by the foot of the bed. And I think in an emergency situation, it could have gotten bumped with the bed as we tried to move it out. So I think I would, if I did this again, I think I would move that container and put it somewhere else. That's one thing that I noted from this when we did it. I think this is, as you can see, it's just a rough drill to think about what you're going to do in the response. And you can get and refine these all you want. But I think the importance of it is you don't have to do, an elaborate procedure to try to run through these procedures. You just need to get something to recreate the emergency and to go ahead and do it. I think the more times you can do it, the better. So let's talk about the roles that each person plays in the emergency response. The physicist is the director of the response. They're really in control of everything. And I think that's important when you educate your staff, that they understand that. This is the point where we get to be in control. We're going to initiate and direct the emergency response. We need to remain aware of the radiation monitors and our meter readings. We need to activate the emergency stops. We need to try to manually retract the source, if possible, with the hand crank. I know versions of Nucleotron have the same type of hand crank. It's just where it's located is different. We need to help the physician secure the source as necessary. If they're taking that applicator out of the patient, we need to help them and guide them through that so that they're not getting a whole lot of hand dose, so that they're not grabbing a bare wire if a bare wire is there, so that they're using the tongs. We need to survey the patient and be responsible that our meter's working correctly. We need to make sure that you do that check, do the check source and the battery check on that meter before you start in the morning. It's important. And we need to contact the vendor and any other agencies that help you with your sources and to maintain source security as well. The role of the nurse, you want to make sure that each person understands their role. We understand our role, but a nurse coming in might not. It may not be the most aware of what their role would be in this response. So we'll need to really do good education, helping them understand how we want to rely on them during the response. We'd like them, or it could be another person, depending on how your workflow works. If you have a therapist or some other person in the room, a medical officer, I don't know who, depending on your country, what you're using and how your personnel look like. But somebody needs to assume this role to utilize the stopwatch and a notepad to record times each individual enters the vault and the end of response. And these need to be general. I mean, as accurate as possible, but the most important thing is to get an estimate of the dose for each person. Noting general positions. If the nurse enters the room, did they go to the head of the bed or did they stay by the physician? We educate to stay by the head of the bed if possible in most responses, because unless it's a skin lesion on the face, then of course we'd want to stay closer to the foot. But for gynecological procedures, head of the bed, if they're needed to calm the patient, which is one thing they might need to do in an emergency response, to enter the room and help calm a patient. The role of the physician, they're going to need to remove the applicator as necessary, and also in helping calming move the patient. That's the unpredictable thing in this whole scenario. You don't know what the patient's response is going to be, and you have to be prepared that they may get panicked because they know something's not going right, and you have to be prepared to deal with that as well. Okay, a summary response. I mainly put this one in there if you want to go back and look later. This is a really busy slide, but I'm going to go through it just one more time. You can study this at your leisure. The physicist is going to note the error in the treatment and verbally initiate emergency response. I think that's important. We're gonna know that there's something wrong with that unit, but we need to tell everybody else in that room. They may be charting, doing something else. They may, who knows, but they need to understand that there's an emergency going on. The physicist is going to push the emergency stop button on the console, and they're going to look at the display and the in-room radiation monitors to determine if the source is retracted. Remember, those in-room monitors may not go off for a very thick patient and a weak source. A physicist is going to direct the nurse to record times, or I put a nurse there. It could be another person that you want to have do that in the room. Somebody else that's on your team can do that as well. Physicist is going to push the emergency stop button on the afterloader and to attempt to manually retract the source using the hand crank. If that doesn't work, they're going to have to request a physician to enter the room to remove the applicator. The nurse or someone else can enter the room if a patient needs to be calmed. If they don't need to be calmed, we want as few people in that room as possible. The physician is going to remove the applicator, and the physicist is going to assist them in securing the source in a shielded container. The patient's going to be surveyed in a low background area. It's important that you take the patient away from where you think that source that you've just placed in that lead container. There's still going to be radiation in that room. You need to move them away so that you can survey them to get a low background area, okay? And then the physicist needs to worry about source security and help contacting the right people, RSO, vendor, such. Important things to remember. Once again, really busy slide. Just these are topics to think about. Physicists must be in constant observation of the console patient and in-room monitors during a procedure, all procedures. I think we all are, I know I am, fall short of what I should be doing sometimes about how well I'm paying attention. You know, you start to daydream or something like that, start to make a note on something else. It's important to be present in the procedure and just to watch the monitors and the screen to make sure that everything in your treatment is happening correctly. Eliminate the distractions in the room. We talked at length of how with a weak source and a large patient, the in-room monitors may not always be activated when the source is out. Less time in the room with the source, you get less exposure to the source. Response personnel shouldn't enter the vault unless it's necessary. And distance, we talked about the rules of thumb about exposure. And when inside the vault, you want to remain a meter away if you can, if possible, and minimize the time in which extremities are within 10 centimeters. Use the tongs to handle the wire. I kind of use those 1 meter and 10 centimeters just because they're easy to remember, and I think I can remember those in an emergency to keep my extremities away from 10 centimeters if possible. If I do have to go in to help with that applicator and I'm not actively touching that applicator, I can move my hands 10 centimeters away and reduce the dose to them significantly. Shielding, when the source is in the patient, it's partially shielded. We've talked about that. You need to make sure you're using an appropriate meter to survey the patient. And you need to use a shielded container when you take that source out. I will say, if you are unable for some reason to get that source or that applicator in that shielded container, there may be a situation you'll have to think about this. What do we do if we just have to let it, dangle in the center of the room? How is that going to affect our emergency response, or how we secure the source, or what we do? That's something to consider. And finally, frequent drills really help ensure an appropriate emergency response. So in summary, you do really want to develop and think about your policies and procedures to address the major emergencies. You should use vendor information, and if you don't have that, somebody in our community should be getting you that, because it is valuable information, and you need to make sure you're complying with local and or federal regulations. Be aware of what the regulations are in your country, which I'm sure you are. Proper equipment must be readily available for a successful emergency response. We need to make sure it's there and working, and we need to educate each member of their role. And finally, just get in and do some drills. They don't have to be perfect. Just start them and refine them. And over the years, you're going to get really good at them. I keep refining them, keep getting better at them. And that is the talk.
Awesome. Thank you, Steve. That was really great. Does anyone have any questions? You can either unmute your microphone and ask them, or type them into the chat and I can read them out. No questions? Perfect. Well, I will upload a recording of this session so that everyone has access to it. And if you come across any questions, you can let me or Steve know. You guys should have his contact and his email. So
yeah, I would be happy to provide any other information. More than happy, or just to have a discussion with anybody, because I'm sure I would learn a lot from it as well.
Yeah. So, well, thank you everyone for attending, and thank you again, Steve. This was really great.
Thank you.
Awesome. Okay.
Thank you.
Perfect. Thank you, everyone.